This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. Delighted you're with us today. You know, Thomas, last week we talked about spring break with Cindy Burnett, and one of the elements we talked about was sexual activity. We're going to elaborate on that today and talk about diseases that can be contracted from sexual activity.
Yes, and here's an interesting statistic. Now, worldwide, according to the WHO, there are 1 million new STIs contracted every single day. Wow. And the CDC says 26 million of those per year are right here in the United States. We'll hear some local statistics in this interview, so this is definitely relevant.
We've got Dr. Helen King with us today. She's an assistant professor in the Division of Infectious Diseases in Geographic Medicine at UT Southwestern. And also she serves as the HIV and sexual health provider at Parkland Health and Hospital System. Dr. King, welcome to the show.
Thank you so much for having me.
You know, I think to help set the stage for our listeners, many people may not realize within the United States, and even then within Dallas County, how many people are infected with sexually transmitted infections?
Well, we are seeing increasing trends in the U.S. and in Dallas County year after year of sexually transmitted infections. In 2018, the CDC estimated that about 1 in 5 people in the U.S. had a sexually transmitted infection that year. And then here in Dallas, we've seen similar record high trends of sexually transmitted infections like chlamydia, gonorrhea, and syphilis. And even in recent years, we've seen over 19,000 chlamydia infections alone per year in Dallas County.
You know, I know you mentioned a few of the names, but to help our listeners a little bit, as you look at the sexually transmitted infections, what would you say are the most common that we see in the United States?
So most commonly we see chlamydia, trichomonas, genital herpes, and human papillomavirus, or HPV. But we are also seeing quite a bit of gonorrhea, syphilis, HIV, and hepatitis B.
So let me ask you this. Some of these may have symptoms, some may not. Can you help our listeners understand the symptoms that they do cause?
Sure. It varies certainly by which infection we're talking about. Some STIs are more often than not asymptomatic or without symptoms, like chlamydia. A lot of people who have chlamydia don't know that they have it because it's very frequently without symptoms or very mild symptoms. But symptoms that you may expect if you have a sexually transmitted infection might be discharge, vaginal discharge, or a genital discharge in general, depending on what the infection is. And obviously, for infections like HIV, there may be different symptoms or no symptoms at all.
Does blood work catch STIs?
So some STIs are caught through blood work, and then some are caught through swabs or urine samples to test for the STI at that site.
So syphilis is a very serious disease, especially in later stages. CDC data, the Centers for Disease Control, shows that syphilis in newborns is on the rise in this country. How concerning is that to you?
Yes, this is a very, very concerning trend that we're seeing with congenital syphilis or syphilis in newborns. And it's kind of mirroring the trend and the adult population that we've been seeing. So syphilis in newborns can be a very, very serious condition, and it can lead to premature birth or even pregnancy loss, as well as serious impact on the health of the newborn. So this is a very concerning trend for something that once was nearly eradicated in the U.S. Now we're seeing that in the last 4 to 5 years that the rates of congenital syphilis in the U.S. have nearly quadrupled, and our numbers in Dallas really are increasing significantly even in the past year. I think we've gone from less than 30 cases in 2017 and then up to 60 cases in 2018. It's a really steep increase, and so this is concerning.
When you think in terms of syphilis can be passed to newborns, are there other STIs that can be passed to newborns?
Yes, definitely. And so two that we also worry about are chlamydia and gonorrhea. These two can be passed to newborns during childbirth and can threaten sight for the newborn by causing a serious infection of the eyes. And they both also can increase the risk. If a mom has chlamydia or gonorrhea, can also increase the risk of preterm labor or pregnancy loss, miscarriages.
If a male or female suspects and they're showing symptoms that they may have an STI, should they go immediately to a physician, the public health department? What is your recommendation?
Yes. If you have symptoms and you're concerned that they might be due to a sexually transmitted infection, I would recommend that you get seen as soon as possible. There are many places you can go to get tested for STIs. The health department is certainly one. If you have your own doctor that you trust, then go to your own doctor or healthcare provider to get tested. And there are a lot of community clinics, sexual health clinics around the county that can also provide testing, as well as urgent care centers.
And, I know it's a delicate subject, but if someone does test positive, it's important, and I'm assuming it's very confidential with their provider or the public health department, that they notify their partners so they can get treated. Is that correct?
Yes, sir. That's one of the most important things that you can do if you get diagnosed with a sexually transmitted infection, is to inform your partners so they can go get tested and treated and prevent not only you from becoming reinfected with the STI, but also prevent other people from acquiring the STI.
You just brought up a good point for our listeners. If you have an STI and you're treated for it, but as you indicated, the partner is infected and is not treated, you could easily get reinfected, correct?
Yes, that's correct. It depends on what type of infection we're talking about. Some sexually transmitted infections are curable, like chlamydia, gonorrhea, and syphilis. And then others, like HIV or human papillomavirus, are infections that you will live with. Now, HIV is completely treatable, but for infections like gonorrhea, chlamydia, and syphilis, you can easily become reinfected, and actually reinfection rates are quite high for those infections.
We're listening to Dr. Helen King, who is with UT Southwestern Medical Center and Parkland Health and Hospital System, talking about this very relevant issue that is pervasive of all age groups, really. We'll talk about that and how to talk to your kids next on the human side of healthcare. Stay with us.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
The World Health Organization says over 1 million sexually transmitted infections are contracted every day worldwide. And the problem is on the increase in most locations around the world, including right here in Dallas-Fort Worth. We're continuing our conversation with Dr. Helen King from UT Southwestern Medical Center and Parkland Health and Hospital System. Steve?
As you look at people that have STIs, is it all ages? I mean, we just mentioned a newborn, of course, that's born with it, but as you look at middle-aged people or either seniors in living facilities, how often in the different age groups do people have STIs?
So while it is much rarer to see STIs in seniors, we certainly have seen infections in seniors and even the newsworthy outbreaks occasionally. However, the main ages that we see STIs are in the 15 to 24 age range, and then also 25 to 34-year-olds when we're talking about infections like HIV and syphilis. So still our adolescents and young adults, we're seeing the highest numbers of STI infections or new STI infections. But you bring up a good point that age does not matter here. You know, when you are having sex, then you still can have risk for sexually transmitted infections. And so it's important that we don't forget that.
You know, it's important to treat STIs as soon as possible, I'm assuming, because there could be some long-term health implications for the individual if it goes untreated. Is that correct?
Yes, it certainly is important to identify STIs as soon as possible and get them treated. Different infections can cause different sorts of diseases as they progress. And so infections like chlamydia and gonorrhea, which we're seeing increased rates of, have the potential of causing infertility in young women. And so actually some of the most common causes of infertility in women. And so it's important to get tested so you can prevent that from occurring. And additionally, infections like HIV, the longer that you have HIV without knowing it, the more likely it will be to progress and cause serious health concerns.
You know, you mentioned HIV, and I think, you know, obviously for the last 2 going on 3 years, we've talked about a pandemic and an epidemic, but, you know, we still have an epidemic of HIV. What are your thoughts on the HIV infections currently in the U.S. and specifically in North Texas?
Yeah, so that's a great question and something that's a really important issue for me. We are seeing that despite having really effective ways at preventing HIV, we've really struggled to bring down the number of new diagnoses that we're seeing both in the U.S. and here in Dallas and North Texas. You know, we just recognized the 40th year of this epidemic this past June. The first cases were reported in June of 1981. And we've come a long way with HIV treatment and prevention, but yet we're still seeing way too many cases. And so there's a lot of effort, both nationally and here in Dallas, to really tackle that and do better at preventing HIV in our community.
You know, for our listeners, can you refresh everyone on what are the different stages of HIV?
Of course. So when you first become infected with HIV, you might have an early infection or an acute infection. And so you may get symptoms at that point, symptoms that are kind of like, seem like a flu, fevers, muscle aches, lymph nodes that are big and swollen, and sometimes a rash. And that generally occurs a few weeks after you become infection and may last before you become infected, and then may last for a few days or up to several weeks. And some people don't have symptoms at that point and they just never know. And then once that acute infection is passed, then a chronic infection develops, and the virus will replicate, and it slowly over time attacks cells of the immune system. And often for many, many years, someone may not know that they have HIV, and then ultimately, without treatment, would progress to acquired immunodeficiency syndrome or AIDS. And that's when your immune system is damaged to the point where you're at risk for getting other infections.
You know, I know there's no vaccine that you can use for HIV, but is there an effective cure currently for HIV?
So there's not currently an effective cure or vaccine for HIV, unfortunately, though there's a lot of effort and research going into both of those. However, with medications and routine medical care, you can control HIV. So people who get diagnosed early and get on their HIV treatment can be on as little as 1 pill a day and live a long, healthy life.
Can HIV, in your mind as a physician, be prevented?
Absolutely. We have a lot of very effective ways at preventing HIV. So obviously getting everybody who has HIV diagnosed as early as possible and on medications is a good place to start. So we know that people with HIV who are taking their medications and have suppressed the virus from replicating, they can't actually spread HIV to their sexual partners. And then in addition to that, for people who test negative for HIV but have risk of acquiring HIV, they can actually take a medication to prevent them from acquiring HIV, and that's called PrEP. It's very highly effective at preventing HIV.
You know, we've got listeners, who I'm sure we've got listeners today that are teenagers, young adults, and older adults. And when you think in terms of sexually transmitted infections and all the things you described, what would be your message as the best defense to prevent STIs?
Well, it may sound cheesy, but I think that knowledge is the best defense against STIs. I really want to make sure that our community members feel empowered to make safe and healthy decisions about sex. And if you want to get into specifics, we know that condoms are effective at preventing STIs, but only if you're using them correctly and consistently. And getting tested for STIs regularly if you're having sex is very important for the reasons that we mentioned. We want to diagnose STIs early, and they may not have symptoms, so this can help you detect them. And then making sure your partners get treated so you don't get reinfected. And then also that medication called PrEP. If you think you might be at risk for acquiring HIV, then you should talk to your provider about PrEP.
You know, Dr. King, we've covered quite a few questions. We've talked about STIs. But to our listeners, what questions should I have asked you I didn't, so you can convey a special message to them?
Yeah, I think maybe talking a little bit about the unfortunate fact that we still see stigma around sexual health. And I just want to send the message that we all make decisions every day that impact our health. I'll give you an example. Today, I made the impulse decision to order French fries with my lunch. And I don't expect that you or anyone else would pass judgment on me for making that decision. However, I know it clearly wasn't the healthiest choice to make. Decisions about sex should be no different than that. There's really no place for stigma or shame around your sexual health. I know that it's a highly personal topic, but we need to all feel really comfortable discussing openly sex with your health provider and really seeking out routine testing. There should be no shame around that. You're trying to keep yourself healthy and safe.
Dr. King, in your opinion, especially as children become adolescents, how soon should parents have a discussion about sexual health and STIs with their children?
So I think starting at a young age, obviously age-appropriate education about sex and about sexual health is important. But as your child enters into adolescent years, 12, 13, there are studies that have shown that adolescents as young as 13 are really engaging in sex. And so being sure that they're equipped with the knowledge they need to make healthy choices is important. What are their options for prevention of STIs, and how can they make the right choices for them? It's important.
This is Dr. Helen King. She's an assistant professor in the Division of Infectious Diseases at UT Southwestern Medical Center and works as a sexual health provider at Parkland Health and Hospital System. What sexual diseases can be cured and which can't? And especially how to have that candid conversation with a new potential sexual partner before you get exposed. Then we're going to talk about prostate cancer in men with Dr. Matthew Cavey following that. Lots of good information coming up next on the human side of healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
We're finishing up our interview with Dr. Helen King with UT Southwestern Medical Center and Parkland Health and Hospital System, talking about this rampant expansion of sexually transmitted infections. According to the WHO, over 1 million per day worldwide.
Can you explain to our listeners a little bit about what's a curable sexual transmitted disease and a non-curable? For example, bacterial sexual disease versus viral sexual disease.
Yes, generally, most bacterial STIs are curable, and that includes chlamydia, gonorrhea, and syphilis. Infections like HIV and human papillomavirus and herpes simplex virus, which causes genital herpes, those are viruses, and those infections are not curable.
You know, today, 50% of couples end in divorce, so there are a lot of single people out, people in different relationships. And even if you're in a relationship that's monogamous, your partner may not be. So if you're sexually active, how often should you be tested for sexually transmitted diseases?
So it really depends on whether you're having sex with one partner or whether you've had more than one partner. Generally, it's recommended for adolescents and young adults to get tested annually, at least for gonorrhea and chlamydia. Everyone should get tested for HIV at least once during their adolescent or adult life, if not more frequently, depending on their sexual practices.
What is your advice on how you discuss in a very frank manner with someone before you become sexually active with them?
So just expressing to your, if you have a new partner, to your new partner that you want to make sure that you have a safe and healthy relationship. It's always a good idea when you start a new relationship for both you and your new partner to get tested for STIs at the beginning of that relationship so you can start fresh and know that you're both going to have a healthy relationship.
You know, during the pandemic, we all learned a new word, shedding those viruses. So how are these sexually transmitted infections really spread?
Yeah, so these are generally spread through contact with genital secretion, so through sex directly. Some can be spread through blood, but generally through genital secretion.
You know, you have herpes virus, simplex 1 and 2. How common are herpes?
Having herpes simplex virus is very common, both HSV1 and 2, and both HSV1 and 2 can cause genital infections. Not everyone that has HSV1 or 2 are going to have the classic outbreaks, painful ulcers that you think of, and so not everyone will experience symptoms from them.
A big thanks to Dr. Helen King in the Infectious Diseases Department at UT Southwestern Medical Center and a sexual health provider at Parkland Health and Hospital System. Steve?
You know, this next topic is very near and dear to me because I've had prostate cancer. In fact, I'm 4 years survivor thus far and certainly hope to continue. But I will tell you, early detection is the best prevention related to having severe prostate cancer.
And what makes it especially relevant for guys, as you're going to hear, is there's a pretty good chance at some point we're all going to get it.
We're delighted that we've got with us Dr. Matthew Cavey. He is a radiation oncologist at Texas Health Harris Methodist Hospital located in Fort Worth. Dr. Cavey, welcome to the show.
Well, thank you so much for having me.
You know, for our listeners out there, I know they hear about prostate cancer, but I think it's important to hear from you, a professional, what you really define prostate cancer, and then also How common is it among men?
Yeah, prostate cancer is a malignancy in the prostate gland. The prostate gland is in the male pelvis, below the bladder and in front of the rectum. And the urethra passes through the prostate gland. Prostate cancer is the most common cancer in men, and approximately 1 in 8 men will be diagnosed with prostate cancer in their lifetime. And it's also the second leading cause of cancer death behind lung cancer.
You know, when you think in terms of prostate cancer, what are some of the screening techniques, and how have they changed over the years to make it easier and more effective?
Screening used to consist simply of a digital rectal exam by the primary care physician. And then there was the prostate-specific antigen or PSA blood test. But more recently, there have been new tests like biomarkers and advances in MRI imaging that allow for us not only to diagnose prostate cancers, but more importantly, to diagnose cancers that are aggressive and require treatment.
You know, the advice you just gave, Dr. Cavey, is so good. To be totally transparent with you and with our listeners, I was diagnosed with prostate cancer 4 years ago, and it's precisely the way you described it. I went to my primary care physician every year for an annual checkup, had my PSA checked, a digital exam, and it was caught early. So my point and question to you is, how soon should men have their PSA checked, and how frequently should they have the digital exam?
Yeah, the recommendations change somewhat frequently, but typically a man should start screening at the age of 45 unless they have high-risk features. And so in some men, it's recommended to start at age 40. But the digital rectal exam and the PSA are recommended annually as part of the screening.
So when you talk about high risk, let's assume that an individual has prostate cancer and they have 2 sons. Would you assume the sons are high risk and they should start at age 40? Or what is your recommendation?
So in order to determine if they're high risk or not, typically there would be a genetic evaluation that would be performed. But typically, yes, if a man has prostate cancer, his sons are typically going to want to start that screening process at an earlier age.
Thank you. And I know some of the steps that then happen are biopsies. What is some of the new approaches related to biopsies if one is needed?
Typically, a urologist will perform a ultrasound-guided transrectal biopsy of the prostate, meaning that the needle passes through the rectal wall and into the prostate gland. There's a couple of issues with this approach, and one, that it is passing through the rectal wall, so there's risks of infection. And then secondly, it's sort of a random biopsy in that it's not a targeted biopsy, but just random points in the prostate gland are sampled.
So if you're having a biopsy done, is it generally followed up with what you mentioned earlier, some of that MRI work, or is that separate and distinct?
So these days, a newer approach to prostate biopsies is to perform what's called an MR fusion transperineal prostate biopsy. So this approach to prostate biopsies is different in 2 ways. First, it's targeted. So there's special software and equipment that allows the exact locations in the prostate gland that are identified by the MRI to be biopsied. And then secondly, the approach is through the skin of the perineum, which is the skin beneath the scrotum. So the needle passes just from the outside in instead of passing through the rectal wall. So this results in fewer infections and also allows for all areas of the prostate to be adequately assessed.
You know, I know if anyone is told that they're diagnosed with cancer, it's very alarming and emotions run high. But to our listeners out there, if they are diagnosed with prostate cancer, what do you recommend as the options for treatment that they may pursue?
Yeah, first and foremost, what I tell most of my patients is if they do indeed require treatment, they are most likely not going to die of their prostate cancer. And there are many patients who have low risk or unaggressive disease that don't even require treatment. We just put them on an active surveillance protocol, which these days includes annual PSA and imaging such as an MRI scan. If patients do indeed require treatment, the two treatments that are recommended are either surgery or radiation therapy.
When you see a patient, and of course I understand you are a radiation oncologist, but is there ever a situation where a patient needs surgery and not radiation, or vice versa, where you think one treatment is better than the other?
Obviously, as you noted, I am a radiation oncologist, so I have my own inherent biases, but surgery and or radiation therapy are often good options for almost all patients. I prefer radiation in many instances because we're able to address not only the cancer cells that are inside the prostate gland, but we're able to treat those cancer cells that are hiding outside the prostate gland. Whereas with a surgical procedure, you're only addressing the cancer cells in the gland itself.
You've talked about some of the great things that have happened, especially in diagnosis and treatment of prostate cancer. As you look to the horizon, do you see some treatments that you feel that will be with us sooner rather than later?
Yeah, there's a whole world of treatment of cancer patients, which is called theranostics. So the word itself combines therapy and diagnostics. So the most simple explanation I can give of this is it's using essentially like heat-seeking missiles that are injected or infused into the patient's body, and these specifically target and destroy cancer cells. So it's a very exciting field that is right on the horizon and will be utilized to a great degree in the near future.
More on prostate cancer, which affects all men basically at some point, next with Dr. Matthew Cavey on the human side of healthcare. Stay with us.
Covering the healthcare topics that matter most to North Texas. This is the human side of healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
We're continuing our conversation with Dr. Matthew Cavey. He's a radiation oncologist at Texas Health Harris Methodist Hospital in Fort Worth, and he says that all of us guys are going to get prostate cancer at some point if we live long enough, which makes monitoring our PSA regularly so important.
You mentioned PSA in our earlier segment. Can you explain to our listeners, especially the men, why it's so important, even after prostate radiation treatment or surgery, to have your PSA checked routinely?
Because the PSA is what we use to help us determine if there's cancer cells that remain. So when a man has surgical removal of his prostate, his PSA should be 0. And if it's not, then it likely means that we have prostate cancer cells that have been left behind. When a man is treated with radiation therapy, the PSA will fall greatly, oftentimes to less than 1, but it doesn't have to go all the way to 0 for a man to be in remission. The PSA just has to go low and stay low.
Do you still look at Gleason scores when you're diagnosing prostate cancer, or is that now an obsolete term?
No, sir. It's a critical factor in classifying how aggressive a patient's cancer is. So it's oftentimes the most important factor, but it's used along with the PSA level and also the clinical stage, or whether or not the cancer can be detected physically or by imaging scans like an MRI.
Dr. Cavey, you've done such a good job of educating about prostate cancer. What message would you like to convey to the men that are listening about prostate cancer?
I think that it's very important to have routine screening, but also to utilize these new methods of screening and diagnosis like biomarkers and MRIs, so that we're able to not only diagnose the aggressive prostate cancers that may be hiding, but also to limit diagnosis of cancers that simply do not need to be treated. I know that last part is somewhat difficult oftentimes for patients to understand, but there just simply are many cancers that are not aggressive enough to warrant treatment. And thus, it's important not necessarily to diagnose those, which would lead to unnecessary anxiety over the diagnosis.
Is there an age a man reaches where he no longer really needs to have PSA annual checkups?
There's probably no hard and fast number because it's going to depend on the patient's overall health. But typically, somewhere around the age of 80, with normal overall health and wellness, it becomes less important to continue to do PSA screenings.
Dr. Cavey, if we don't have to cross the bridge, it's always better. How can men prevent prostate cancer?
It's felt that maintaining a healthy lifestyle with diet and exercise is your best bet, although there is no true way of preventing prostate cancer.
Why is that?
Mainly that prostate cancer is an aging phenomenon, so that if a man lives long enough, even if it's not known at the time of death, you'll most certainly have some evidence of prostate cancer in the gland.
So that's inevitable.
If a man lives long enough, yes. Cancer is, primarily a disease of aging. And if you live to be 90 years old and you happen to have an autopsy, it's almost certainly that there would be prostate cancer found.
So a lot of men might die in their 80s and 90s having prostate cancer and not even knowing it.
Certainly. And also, many men may die with prostate cancer who are under active surveillance and do know it. So there's many times when a patient has what we call low-risk disease or Gleason 6 cancer, they often do not require treatment because it's such a slow-growing process.
So just like you and Steve discussed, if you are diagnosed through perhaps a PSA test that's elevated, and that leads to the visit with the urologist or whoever diagnoses it, that it doesn't necessarily even mean that you might need to treat it with all the factors that could be considered.
That's absolutely correct.
Wow. So it's not that shocking jolt of like stage 4 lung cancer or something like that. Not at all by any means.
Not even close. And that's why there is an effort to try to limit diagnosis of cancers that we would not recommend treatment for, which gets back to the whole idea of accurate diagnosis.
Well, exactly. And I know that, as you guys have been talking about, that over the last decade, that has improved significantly.
Most definitely, especially with the biomarkers and the high quality resolution of new MRI scans. What we're able to do and diagnose is far greater than it used to be.
Boy, that would be put your crystal ball in front of you and wave your hands over it a little bit. And what does it look like a decade from now in 2032? What kind of technologies might we have?
In addition to the theranostics, I think from a therapy standpoint, improved imaging of the prostate gland will allow for us to do more focal or focused treatment of the prostate gland. Presently, we treat the entire gland when we have a prostate cancer simply because we don't know where it starts and where it ends. But in the near future, with better imaging, we'll be able to more accurately define exactly where the cancer is and where it is not, so that we can do focused therapies, which will be even better tolerated than the treatments we give today.
My son is a biomedical engineer at one of the local hospitals, and we were talking the other day about some of the technological things that he sees and has been dealing with. And we were talking about virtual reality, and he was saying, Dad, you need to really pay attention to this because this is how you're going to be communicating with your granddaughters. And I wonder if virtual reality might come into this kind of screening where we can actually zoom in and see it from a full perspective without invading the body.
Certainly it might be possible. I would probably say more on the horizon would be the use of artificial intelligence to help us with our computer planning that we do prior to and even during the delivery of treatments like radiation therapy.
Your side of medicine is truly one of the coolest parts because you get to play with all the toys when they come out, and you get all these really great new technologies to use in your treatment and in your practice. That's great.
Yeah, it's part of what attracted me to the field to begin with, because I too was a biomedical engineer as an undergrad. And so the technological aspect of the field certainly was appealing. But in addition, there's a very human side of it as well. We make a dramatic impact in our patients' lives when we're able to cure them of cancer. So it's hardly a thing I can imagine that was more rewarding.
Wow, that's a great combination. So you were an engineer, and then now you're using that technological background in your medical training and treating patients. That's awesome.
Yeah, it's a blessing to be able to be in this field.
Dr. Matthew Cavey from Texas Health, Harris Methodist Hospital in Fort Worth, thank you for that great education on how we guys can take better care of our prostate.
Thomas, what a great show today. We've had some terrific guests. And, I just wanted to update our listeners a little bit. We're very thankful that we've seen our COVID hospitalization numbers down. We're feeling a lot more confident. But I just want to put one word of caution out there. This Omicron BA.2 variant is spreading rapidly in other countries. In fact, it seems to spread 30% more easily. And it's my understanding from doctors, it makes you a little sicker than the original Omicron. So we're thankful, we're celebrating, but let's be cautious. And one other thing I'd like to mention. I've talked to some of our large emergency rooms this week, and flu is on the increase. Now, I don't have any scientific evidence, but I think not wearing masks as much is impacting that.
Okay, so for the most part, the mask has been shucked aside. But here's the deal. How sick do you want to be? We had Dr. Robert Haley from UT Southwestern, and he told us of this study where they took guinea pigs and tested them with various mask-simulating substances around their cages and proved without a shadow of a doubt that masks prevent a full inoculum of a virus. And that's the question. Other cultures have used these for a long time. It's just a matter of, do you want to get sick or not?
No question. One of the best tools in the toolbox. Thanks for joining us today, and we'll see you next week on The Human Side of Healthcare.